Okay, so I think I'm recording. Am I recording? I can't tell. So we're going to do substance abuse since we weren't able to get this PowerPoint in class. But everybody who covered this topic did an excellent job, and I thank you again for your contribution. That was wonderful. But just to fill in any holes or something maybe that wasn't focused on in your PowerPoints, but that we might have been in Darby and Walsh. We'll just go through this quickly. You can read through those objectives on your own. So what to consider when filling out your patient, when your patient is filling out their health history form. So obviously, just like you guys always do, you're going to look at the tobacco use, the alcohol use, the marijuana use, and any illegal drugs, street drugs that might be used. The term substance misuse has sort of been encouraged over substance abuse. Substance misuse is a pattern of self-administered drug use that can lead to drug addiction. So obviously using it when it's not really necessary, using it to dull feelings of depression or to just get that euphoric feeling instead of using it for like a therapeutic reason. A substance is a psychoactive compound with the potential to cause health problems, the substance use disorders and addiction. And then the three main categories of that are alcohol, illicit drugs, and then also over-the-counter drugs can also be used in different ways as well. So misuse versus abuse, it's just a little bit more, I don't know if politically correct or socially, it doesn't have such a negative connotation. So you'll still hear substance abuse a lot. I still say it probably 3/4 of the time because those terms, when they are trying to be changed, you just get in the habit and it's hard to alter your speech pattern. But basically misuse is trying to be a little bit more sensitive to that negative connotation of substance abuse. So. Research has shown that drug addiction is chronic and it's sort of a cyclic disease. Yet, unlike other diseases, it does have that social stigma. So people don't oftentimes have the same sort of sympathy for somebody that has a drug addiction as they might for somebody who has, Parkinson's disease or something like that, where they just think, well, that's not their fault. That just happened to them. Whereas they're like, they're choosing to do this and they've made bad choices and stuff like that. So there's sort of a social stigma, but they have done research that shows that a lot of times there is a genetic disposition to it and it's classified as an actual disease. So poor oral health is common among patients who will misuse illicit drugs and other addictive substances. Substance misuse directly affects oral health, particularly increased caries, enamel erosion, periodontal disease, as we saw in the various presentations, and then just sort of a tendency to not keep yourself as hygienic. So neglecting your oral self-care and your physical self-care. So addiction, dependence, withdrawal, and relapse. Drug addiction is the prolonged, repeated misuse of a substance, a chronic and compulsive need to use drugs despite their causing the user physical harm. So even though they're not, that initial high felt so great, but now they're starting to feel those deeper downers, but they just keep on returning to try and reclaim that good feeling and those positive things. And even when things start to go really bad, like their teeth start to rot or erode, or they lose their job or they lose family, that they'll keep doing it even when these things start causing problems. Psychologic dependence is rooted in the belief that the drug is needed to maintain that state of well-being. Psychologic dependence results from a biologic alteration in the user's brain from constant use of that drug. So neuro pathways and neurotransmitters, they actually change function. And then the patients, like they talk about our brain being plastic, and our repeated habits actually form these sort of pathways in our brain. And so this repeated misuse of these certain psychotropic trophic drugs and things that actually alter the chemistry of our brains, they make permanent changes in the brain, which therefore make it harder and harder for the patient to quit, to stop using. Withdrawal symptoms may include vomiting, diarrhea, rapid pulse, sweating, anxiety, convulsions, severe cramps, high blood pressure, severe headaches. So very uncomfortable, something that they wouldn't want to experience. So thus even more sort of a reason to go and get more drugs to alleviate those withdrawals. And then drug tendency, tolerance, increasingly larger dose is required to produce the same psychological and physiological effects obtained earlier in this smaller dose. I think I said psychological twice up here in this one, but the first one was psychological, the other one was physiological. Sorry, I misspoke there. So here's just a diagram that kind of shows some of the withdrawal symptoms that they might feel, just to give you a visual there. Illicit drugs are a variety of drugs that are used for non-medical purposes and are illegal to manufacture, use, or sell. Over-the-counter, OTC, drugs that are available for purchase without a prescription. Drugs, certain substances and chemicals are classified into 5 categories or schedules. These substances are scheduled in relation to their acceptable medical use. So for a long time, for example, marijuana was like a schedule up there with, you know, I can't even, whatever like the worst ones are. It was just seemed kind of crazy because they're like, there's no medical use for marijuana at all. And so something that really didn't seem as harmful was up there with, you know, whatever, you know, heroin or something. So, but now I think they might have adjusted it, but I'm not sure because clearly there are medical uses now. Hi, did you have, uh-oh, sorry, we got to pause here. Hold on, we got a boo-boo. Okay, we recovered from that. Sorry for that interruption. So drugs, let's see. I think we did this slide already. Okay, I'm gonna advance. Okay, so alcohol misuse, most pervasive substance in the US. So obviously, you know, we drink socially, we drink, you know, some people even drink a little bit every day for their health, because there's studies that talk about, you know, a glass of wine being good for you or something. And so it's pervasive because we use it for, you know, celebrations and just everything that you can think of. And then of course it can be pretty significantly misused as well, associated with negative oral and overall health-related diseases and deaths. The liver breaks down alcohol at the rate of 1 standard drink per hour. 1 in 8 American adults, or almost 13% of the US population now, meets the diagnostic standard for alcoholism. And I almost wonder if that isn't a little bit underreported too. Yes, sweetie. Oh, very pretty. Okay, mommy's working. So can you draw me another picture? Yeah, draw me one more. So here is just a picture with the what equates to 1 drink. So it's different depending on if you're going to drink shots or a beer. It's different. Alcohol poisoning, slow or irregular breathing, less than 8 breaths per minute. The person would be cold and pale and a bluish tone, meaning they're obviously hypoxic or low oxygen, rapid pulse, vomiting while awake or asleep, unresponsive to attempts to awaken, and semi-consciousness or unconscious. Abuse signs, reddening in the skin, this spider petechia, or like the tiny little blood vessels that kind of, you know, they used to say, like when they used to make caricatures of like winos back in the day, they'd have really red cheeks and a red nose, and that's from the dilated blood vessels. Yellowish skin, that's from the liver disease, the jaundice. Facial trauma, maybe they fall a lot, or they could have bruises on their sides if they fall. facial trauma, angular cheilitis. So they're going to be vitamin deficiency, vitamin B deficiency is possible. So they're more susceptible to opportunistic infections and things like angular cheilitis or the candida, red or swollen eyes. And then intoxication, poor judgment, impulsive urges, slurred speech, unsteady gait, lack of coordination, impaired memory, attention, involuntary rapid eye movement. Marijuana is the most commonly used illicit drug in the United States. As of 2017, 29 states and the District of Columbia had legalized marijuana. And I think that the marijuana group had a more updated, I think you guys had a more updated number, so I got to go and grab that from you. Research suggests there is potential therapeutic value of marijuana use, which we learned about, and we know, especially highlighting nausea. They also use it, like we learned about, for patients recovering from other sorts of addiction, and then particularly epilepsy. My best friend's husband is epileptic, and he can't take the medications, and so he uses marijuana, and it does the trick. It does what's needed. So there is definitely some benefit there. Cannabis, other names for it, you can see that there. There's the THC or the CBD cannabinoids or the tetrahydrocannabinoid. Okay, I'm going to pause again. Sorry, Lola had to stay home today, so Mom, we're doing double duty. Mommy, may I watch Dino Dana? Okay, so psychoactive ingredients, and there's the psychoactive portion of the cannabis, and there's the analgesic part, the pain deadening part, and then anti-inflammatory, which is also interesting. Short-term benefits are relaxation, euphoria, maybe confusion's not a benefit, so maybe it's just short-term effects. Confusion, red, bloodshot eyes, intense hunger or thirst, difficulty with concentration, memory, learning. Although it's funny because, you know, sometimes you get anecdotal reports, and then you get some of the stuff that comes in from the studies and the reports that are more official. But anecdotally, if anybody's known people who have smoked pot, which I'm sure there's going to be at least somebody in your world that you're familiar with, a lot of times people that I have known in the past, they would smoke marijuana, and then they would go and tinker on something, and it would like they'd hyper focus on something. So they'd like, so I had a relative who, and he would go out into the garage and he'd work on his car for hours and hours and hours. And so it's funny that they say difficulty with concentration, but I think that it again demonstrates how things can affect different people differently. And there's also many strains of cannabis too that do different things, so that could have something to do with it as well. Distorted perceptions of sight, sound, time, and touch. That's that sort of psychoactive piece as well. And then systemic effects, dilated pupils, tachycardia, so kind of a little bit of a racing heart, peripheral vasodilation, bronchial hyperactivity, insomnia, impaired short-term memory, disruption in testosterone secretion, decreased nausea, which is a positive thing for like cancer patients, decreased pressure behind the eyes, which also I kind of wonder if that could be associated with a benefit to somebody with glaucoma. I feel like I've read that before, but I can't quite remember. So forms of cannabis, there's so many forms now that somebody can ingest, and I am going to do some research on the way they extract the CBD and the THC, because I've read some things about, you know, the actual extraction process can actually be really unhealthy, and because they might extract something from a plant that is in very small amounts, so they have to use a very kind of almost toxic process to get this little amount of something from the plant. And so that's just some interesting, kind of an interesting side note. But since marijuana is federally classified as a Schedule 1 substance abuse under the Controlled and Substance Act, distributing it is still considered a federal offense. This is a note I have from probably 2 years ago, and I don't know that that actually is up to date, especially since we had our overview yesterday. So I'm going to star that note and check to see if the schedule hasn't changed, because it was a Schedule 1, but that might have been updated. So we'll see. So the opioid crisis is major. It's a major public health crisis. Opioid analgesic pain relievers are now the most prescribed class of medications in the United States, although I think they're working hard for that to change, and it may have changed, but I'm not so sure if that is current to this year. With almost 290 million prescriptions written each year, I still think that it's if it's not still the highest prescribed, it's one of them, but I know they're working to reverse that. Both synthetic drugs and opioid drugs derived from the opium poppy plant. Examples would be heroin, oxycontin, Vicodin. We talked about these already, methadone, morphine sulfate. Intoxication, it's extremely dangerous. You can have intense mood swings, impaired judgment, impaired attention, impaired memory, change in your pupil size, slurred speech, drowsiness, and hallucinations. So the opioids can depress breathing by changing the neurochemical activity in the brain stem. So this is where the autonomic body functions are controlled in the brain stem. And so when those are depressed, that can be obviously very dangerous. Opiates can change the limbic system, which controls emotions to increase feelings of pleasure. But a lot of times the downside is quite a crash afterwards. Opioids can block pain messages transmitted through the spinal cord from the body, which of course is the therapeutic benefit that we use them for. The C-shaped limbic system, so this here, the C-shaped limbic system of the brain includes portions of each lobe of the cerebral cortex and is essential for memory function, learning, emotions, and motivation. Many of the responses of the limbic system are autonomic and include unconscious bodily functions. So things that just happen without you trying to make them happen. So understanding the limbic system assists clinicians in addressing involuntary and unwanted behaviors of addiction. So it's pretty complex, and a lot of parts of the nervous system are affected. So here's just a little diagram that sort of shows how the whole process works with the medication. So here's the cocaine molecule is a little white one. So they're using cocaine as the sample. Psychoactive, which is not an opioid. So maybe this was bad now that I'm thinking about it. Maybe I should have used a different image because that's not actually from cocaine doesn't come from the poppy plant. Psychoactive drugs disrupt the normal functioning. So this is just kind of lumping anything that's like a psychoactive. It disrupts the normal functioning of the neurotransmitters. Sometimes this is desirable effect if we're trying to dull pain, obviously. An example effect is desirable if a physician prescribes morphine to alleviate pain. So you can see here that this is the dopamine. Oh, where are we? I'm over here. So this is the dopamine transport, and it's blocked by the cocaine. So when the dopamine is released and it comes over here to these dopamine receptors, and then the extra dopamine is coming back around to be reuptaked. I don't know if you guys remember that reuptake. The cocaine blocks it, so it inhibits that reuptake of dopamine. So eventually this amount of dopamine is going to be diminished because the cocaine is going to have blocked that reuptake. So there's not going to be as much available. So there is a genetic component to addiction and misuse. Some individuals are born with less feel-good transmitters or can't produce as many and may have a predisposition toward opiate and alcohol addiction. And I find this very interesting because I have a lot of family members with addiction and with some depression and anxiety and different mental health issues. And so this makes a lot of sense to me that somebody would reach for something and self-medicate is essentially what's happening. These individuals are often diagnosed with depression and look for alternative means to adjust their mood. So, that's really, it's self-medicating kind of in the wrong area and it's gone awry. It's not the best medicine for the problem, but that's sort of what you can see how some people might be led to do that, which also speaks for a lot of empathy and sympathy and trying to help people navigate these problems. So here's a little review of the stages of change model. It's an approach to assist clients with helping the individual change the unwanted behavior. So only when patients really perceive personal benefit of stopping the substance, that has to outweigh the benefit of using it in order for them to really want to make a change. So we have these different stages of contemplation. They have no thought of stopping the substance abuse, and they don't view their use as a problem. So they're kind of like nope, no thanks. Contemplation, think that they should stop substance abuse someday, but not within the next month. So they're like, yeah, one day I'll quit smoking, or one day I'll lighten up on how much I drink, but not today. Preparation, willing to set a quit date and to begin changing their behavior and thinking related to the substance abuse in preparation for quitting within the next month. So they're setting a date, setting a goal. They want the change to be soon. Action, stopping substance abuse for less than 6 months. Maintenance, stop substance abuse for more than 6 months, and then a relapse if they revert back to the substance abuse. So we can assess for the readiness to quit by asking our patients, would you like to stop use within the next month? And then if they're just like, oh, no, maybe someday, but I'm fine, whatever. However they respond, that kind of gives us an ability to know, and we can make notes and then readdress it next time if we think that it's pertinent, or if we think that they were, like not in any way, shape, or form ready to quit smoking or quit drinking heavily, or whatever it is that we are trying to assist them with. Patient-centered communication, collaboration, not persuasion, eliciting information, not imparting information. These are hard concepts because especially when we know that something is so bad and we just don't quite understand why someone would keep doing something, especially if we see something like just rampant decay. It's like you're losing all your teeth. It's hard to not hold that back and to just simply realize that it's still their choice in their life, and to just basically try to offer the information instead of like making them feel like you're lecturing them. And that's always a balance. It's a hard thing to do. Emphasizing the client's autonomy, not the authority or the expert. So, it is their life, it's their choice. Of course, that can change if they're putting someone else in danger, if their alcoholism puts other people in danger or something, but still they have autonomy to choose and control, how quickly they make the change, or if they even do. So with our modifications, we talked some about this in the different presentations, but the patients may try to pre-medicate themselves. They may show up stoned, they might show up drunk. And so we have to be ready to either dismiss them if we can tell they're under the influence. Hi, okay, sorry, I'm gonna pause again. Okay. So potential need to modify and cancel appointment to avoid any drug interactions or behavioral problems. Cocaine use after oral surgery could affect postoperative bleeding, and dangerous increase in heart rates with local anesthetic with some stimulants. So it could be life or death if somebody comes in with certain, especially a stimulant like cocaine. So that's the most serious situation, but behavioral issues might also be considered fairly serious as well. Did I just skip one? Nope. So reasons for obtaining information is to protect the patient from health risks, and all the information will remain confidential. Questions for alcohol or drug abuse include, have you ever felt the need to cut down on your drinking? Have you ever felt bad or guilty about the amount that you drink? Have you ever used a drink first thing in the morning as sort of an eye opener to help you feel more normal? And if they answer yes to 2 of those questions, then you can suspect that perhaps misuse is a problem. And then substance misuse treatments is not within the scope of our practice. So it's not for us to kind of talk them through it or give them advice, but more just to provide resources for them. And then to also, we can educate them on how directly it can affect their, especially oral health. Explain the relationship of the substance to this systemic relationship, and also talking about the oral health part of it. So IV drug users, there's a higher instance of bloodborne pathogens and getting a disease that way, such as HIV, hepatitis B, C, or D. Hepatitis D? Hepatitis D, why shouldn't it be A, B, or C? I don't, okay, now I need to make a note of that as well. And then long-term, sorry, just making a note, just double checking. Long-term alcohol abuse, of course, affects the liver, the heart, the kidneys, and the pancreas damage. Potentially years of abuse, there can be damage to the reproductive system, permanent brain damage, lack of muscle coordination, there's tremors, drug addiction, cardiovascular disease, stroke, cancer, HIV, hepatitis infection, or lung diseases. EOIO, we want to look at potential things that might be in the extraoral exam and the intraoral exam. In general, somebody who has heavily misused substances for years tend to have an older appearance than what their actual age is. They may potentially look a little bit disheveled, but not for sure. Some people are like high functioning alcoholics and they look the same as everyone else. So it doesn't necessarily mean that they're, you know, we think of sometimes like the worst case scenario, like some of the individuals in the homeless population, for example, that just look completely disheveled and kind of dirty, and they're, you know, dragging themselves around. But that's a very sad extreme spectrum. And there could also be other things involved in that situation, not just drugs, but usually drugs are a big part of it. But then people, you know, there's a spectrum of, so people could be anywhere in that spectrum. But poor oral hygiene is going to, and personal hygiene is going to be pretty prominent, because when you're distracted, you know, or you're feeling depressed, or you're too busy being, you know, inebriated, you're not going to spend as much time on your personal hygiene. They may want to cover up red eyes or dilated pupils with sunglasses, wear long sleeves in hot weather to cover up track marks or needle marks. Alcohol or other odor from the breath. Sometimes you can smell kind of like a rotten fruit smell. I had a patient one time who I had on their breath, I was like, is that fruity acetone because they're diabetic, or is it alcohol? Like, I couldn't tell. And I suspected it was alcohol, but I wasn't sure. They may be lethargic or intoxicated without an alcohol odor. So then we're thinking some kind of other drug, obviously, than alcohol. Tremors, hands, tongue. You may notice tremoring in the tongue, the eyelids, and this can be indicative of alcohol withdrawal. Behavior and speech, confusion, disorientation, lethargy, lack of concentration, memory impairment, extreme depression or agitation. Cocaine, so some things that we want to think of for the intraoral cocaine, there can be gingival lesions, severe bruxism, that flat cuspal plane on the molars and premolar areas from just heavy grinding. Meth mouth is what they call that, rampant caries, the buccal smooth surfaces of posterior teeth, and then the interproximal spaces of anterior teeth, and then the complete destruction of the coronal tooth and tooth structure. So poor oral hygiene, xerostomia, gingival inflammation, advanced periodontal disease, consumption of high amounts of soft drinks, poor nutrition, signs of bruxism, like we mentioned. And oftentimes the teeth will be so far gone, they'll have to have them extracted. If it's alcohol, again, there's xerostomia, poor oral hygiene, gingival bleeding upon probing, coated tongue, glossitis due to nutritional deficiency. Attrition related to bruxism can also be present with alcoholism. Erosion related to vomiting if they tend to get sick a lot. Broken teeth if they fall. And then the buccal cervical caries, especially if they're drinking sweet drinks like sweet mixed drinks. And then chemically dependent individuals will probably need really short appointments. So you have to kind of think about that, how much time they can actually sit still and withstand people doing a bunch of stuff to them. So probably very short appointments. Pain control and anxiety control are going to have to be considered quite carefully. Recovering chemically dependent individuals will need some kind of pain control, but they're going to have to bring in the doctors to try and figure out what to give them. Consult with physicians in regards to local anesthetic safety for chemical dependent individuals. Unrelieved pain can be a relapse trigger. So it's very important to keep them out of pain, but you can't just prescribe them, an opioid. So, it has to be something that is non-addictive. So there's been a lot of research and talk about combining Tylenol and Advil together. They say that the pain control is just as good as an opioid, I'm assuming to a certain extent. And you can take them, you can take the, I should have had the, you can take one every 4 hours and then like one every 6 hours. So they kind of keep loading up. And I can't remember if they take the Tylenol. I feel like they take the Tylenol more often than the Advil. I should have had that in my notes, the regimen. But they work on different receptors, and so they can take them both, and they'll deaden the pain in two different areas of the brain or the body, and so it actually ends up doing very good job of pain control. If needing stronger pain management, you're going to have to consult their physician about that. Controlling anxiety will help reduce perception of pain, and be aware that some patients may exaggerate pain in order to get a prescription. That's what we're kind of always afraid of. And sometimes that keeps dentists from, providing pain medication. But I think on the other end of the spectrum, instead of encouraging patients to come in and get work done, giving an antibiotic for an infection, and then encouraging the Tylenol Advil combination, in general, dentists were far more likely to just write a pain medication and say, you got to get this work done, but here's a pain medication in the meantime. Or giving way too many pain medications after like wisdom teeth. I had a huge bottle of codeine after I had my wisdom teeth taken out. And I think I took one, and then I just had this huge bottle of codeine left that I didn't need. So I think it's been classically overprescribed for a long time. And then, so oral health instructions begin with basic toothbrushing instructions, encourage daily brushing. After this is mastered, introduce the inner dental cleaning. You just don't want to overwhelm them, like we learned in the presentations earlier. When making recommendations, consider the following: their physical, mental capabilities. If lacking fine motor skills, how we can modify those oral hygiene aids. In recovery, required to make numerous behavioral changes, and may see a complex oral hygiene regimen as an additional burden. So if they're already dealing with a lot, we want to keep it really simple for them while they're getting through, should I say, the withdrawals period. And then we have to constantly think about the xerostomia, the nutritional counseling, positive reinforcement, alcohol in any products. We want to avoid that. And then the methadone like we talked about in class, can have a sugary syrupy base, which obviously can be carcinogenic. So those are things to think about. So I think the three groups covered it all very, very thoroughly. I don't think this was as necessary, but there you got another 50-minute thing to listen to if you're up for it. So have a great afternoon, and I'm going to pause.